Thank you so much.
Of course. Hello, everyone. My name is Ashwin Upadhya. I work as a critical care physiotherapist at Liverpool Heart and Chest Hospital. Um, Thank you for joining us today. I know you've had some really amazing, wonderful speakers. Sorry for the technological glitch earlier this morning. Hopefully you can all hear me now, and let's go. To start off with, I wanted to list all the 14 allied health professions as defined by NHS England. Growing up in India, I wasn't aware of half these professions because we don't really have drama therapists or music therapists, at least not when I graduated from physiotherapy school. So for me, when I moved to England, it was really important to know what allied health profession means. And there's a quick snapshot of all the 14 allied health professions as defined by NHS England. I thought I'll start off with a simple definition for physiotherapy. What is physiotherapy? Physiotherapy is a science-based profession and really takes a holistic whole person approach to health and well-being, which includes the patient's general lifestyle. And we help restore movement and function when someone is affected by injury, illness, or disability. We improve their health and well-being. We identify and maximize movement. We promote healthy behaviors and really holistic approach, a whole person approach towards patient care. And at the core of this is the patient's involvement in their own care. So we give that ownership to the patient, and we do that through education, awareness, empowering them, and letting them participate in their own treatment. I know it's quite popular when you think of a physiotherapist, you think typically of a sports physiotherapist, but that's not all we do. There are multiple specialties and subspecialties within the profession that provide a range of physiotherapy services. These could be musculoskeletal, neurological, cardiorespiratory, pediatrics, burns and plastics, women's health, hand therapy, just to name a few. But there are far more specialties within the profession than just being a sports physiotherapist. Nothing wrong with being a sports physio, just so that we're aware that there are multiple other subspecialties within the profession. With regards to COVID-19, COVID-19 has had a massive impact on us economically, socially, physically, and also with regards to our mental health. Professionally, we have been challenged. We must contribute to patient care and the affected patients and identify where can we provide best value within the healthcare system. We're rapidly moving into new models of care that didn't exist before the pandemic. And this may involve reskilling and redeploying staff to expanded intensive care units and discharging patients from our care earlier than usual to maintain the intensive care and hospital bed flow. In outpatients and private practices or in community practices, a lot of telehealth has been used to provide services and to modify into this new model of care. We're also, one of the most important things that has happened because of this pandemic is we've been having to work within new confines of infection control. So it's been very difficult for us to move forward with the standard ways of practice because we have had to have extra PPE and having to have specific infection control measures implemented within our workspace to provide that safe healthcare delivery to patients. And these changes not only influences how we interact with the patient, but also how we interact with the families about managing their own condition. Technology has been a saving grace during this pandemic, where we have been able to maintain a lot of our services through telehealth. These include rehabilitation services in the community, private practices, MSK physios working from telehealth clinics. So the advantage of that is that there's always been opportunity for digital expansion, and now is the time to use that to our advantage and promote a physiotherapy profession that can be done via telehealth. And I've put a link up there which gives you a bit of guidance about how to provide a remote service delivery. It's from the CSP, the Chartered Society of Physiotherapy website. With so many modifications to decide upon and implement with rather an urgency, it is important that we do not reinvent the wheel. There's plenty of resources that are available And we need to utilize these resources that already exist to help us guide rather than trying to find new ways of moving forward. So I think it was in September 2020, CSP did a survey which involved about 4,000 members of CSP, and only 15% of them reported that they're normally offering services that they normally would offer, which is a very small percentage. So it just shows how much impact this has had. And there's been extremely high demand for community services because the rehab needs of patients affected by COVID-19 has gone up, because the number of patients that are getting discharged from ICU to the wards to back to the community, they have larger rehab needs. And to meet this demand, community services have had a huge impact in terms of the demand. And really, the unequal access to rehabilitation and physiotherapy services is a major driver of health inequality, and limiting access only makes it even more riskier to widen this health inequality. One of the key things that came up from this was the increased demands on social care. So it's almost like a dominoes effect, where increased number of patients admitted to the hospital through the emergency department, they go to intensive care, back to the hospital wards, and then the implementation of the discharge to assess, where patients are being clinically optimized and with no acute needs, and then moved on to a different service, and then that's where they're being managed in terms of what exact services do they need. And this has put in a huge impact on our social care system. And musculoskeletal first contact physiotherapists, these have been very vital. MSK physios, FCPs with access to diagnostic facilities are key in managing demand in the secondary care, because this frees up time to manage the backlog that we've had on elective surgeries and elective care. Where I worked, I remember that we implemented programs pretty early in the pandemic and trying to still sustain services like pulmonary rehabilitation. And we utilized our physiotherapy support workers, who were very vital in delivering this care, while the physiotherapists had to be redeployed to ICU to manage the workforce demand. So shout out to physiotherapy support workers who've been absolutely vital in this pandemic. The other thing that came out of this pandemic is the spotlight on respiratory physiotherapists. I think a lot of people were not aware of our role as to what exactly we do in an intensive care unit or managing respiratory conditions in the community. But this pandemic has definitely put a spotlight on us. I've put up some resources here from the Association of Chartered Physiotherapists in Respiratory Care and from the Chartered Society of Physiotherapy Care, just to take a look at it. It provides resources about COVID-19 and how the entire respiratory therapy community came together to come up with these resources, sharing information, sharing knowledge, and ultimately improving patient care. So from an impact on the ICU point of view, we've had to do a lot of workforce planning. So there were therapists that were redeployed from the community, redeployed from other wards, like the orthopedic ward, especially, where a lot of elective surgeries were put on hold. And what we did was we identified people with specific skill set that they brought. So MSK physios and physios working in orthopedic and trauma were put as part of the proning team, because they had more understanding of musculoskeletal care and preventing any long-term injuries that you would get from proning. So it was very key to identify which member of the team had which role to play, so we could utilize everyone's skill set and then utilize that to help with our workforce planning. We've had to change a lot of our rehab and weaning strategies. With the start of the pandemic, it was very difficult for us to know what exactly were the needs of these patients. And these patients were ventilated, paralyzed and sedated for a long period of time, sometimes even more than 3 weeks. So you can imagine the critical myopathy and neuropathy that these patients presented with made it very difficult to rehabilitate them. Most of the times we would need more than 2 physios to perform some of these rehab things. And weaning was especially difficult because these patients required we had to have a lot of patience with these patients because they're fatigued quite easily. So sometimes we would do weaning on one day and rehab the other day, just so that we gave them that enough time to recover. So we've had to change the way we practice just to accommodate to the requirements of these patients. One of the other key things that came out was the pickup stool. It's a rehab prescription which really involves a multidisciplinary team, your dietitians, the speech and language therapists, occupational therapists, and how each member of the MDT can identify the specific needs of a patient. Because most of these patients had a really complex discharge where there were complex needs that were need to be met in the community. So each member of the multidisciplinary team came together with their specific requirements for these patients, and the pickup stool was very helpful in deciding exactly where this patient's journey would take them forward. A lot of trusts across England developed these follow-up clinics where they would the follow-up team would involve a rehab nurse or an ICU physio and try to follow up these patients via telehealth to understand what gaps in service that we needed to address in terms of what services were available to these patients. I know that not a lot of trusts have access to a dedicated psychologist for ICU or a dedicated occupational therapist for ICU, and that made it very difficult to bring all these strategies together to benefit these patients in their journey, in their rehab journey. But what it has given us is the opportunity. There has never been a time more important to raise the awareness of multidisciplinary team working, because it's so vital for patients recovering from intensive care unit, because it really involves all team members together, and the special expertise that these team members bring really provides a holistic approach to patient care. Ultimately, as physiotherapists, we still assess and treat patients informed by the best available evidence. However, we're doing this under different set of conditions in altered work environments and or with new teams. And with healthcare stretched to capacity, we must utilize, as I said earlier, existing resources and decades of research that is still applicable to our current practice. There's minimal standards of clinical practice that have been developed, which are already available, and these can help you guide, train and upskill physiotherapists that are being redeployed to intensive care unit. I think it was on one of my previous slides. So do take a look at that. There is a clear role for physiotherapists as a link between intensive care unit and ward, advising colleagues how best to rehabilitate these patients who are extremely hypoxemic, and fatigue being a major factor. And it's not just the patients that get admitted to intensive care unit. There have been instances where people who probably had a minor response to the virus, but now are suffering from long COVID. Darren Brown, physiotherapist working at Chelsea and Westminster NHS Trust, has done a lot of work on this. Do look him up on Twitter, and I'm sure you can find a lot of information about that. So shout out to Darren. And again, for patients who do survive intensive care, reducing ongoing disability is where we come into play. And that is where our role plays majorly, is to reduce the disability that these patients suffer after a prolonged critical care illness. Just a few final thoughts. It's been a difficult year for everyone, and one of the few things that comes to my mind is just to have that effective communication. If there's something that worries you, or there's something where you feel like your skill set are not strong enough to be applied to a certain clinical area, you need to communicate that to your team members. You need to communicate that to your supervisor, so then they can assign you to an area that is much more suitable for your skill set. But having said that, it's also an opportunity to learn new skill set and apply those transferable skills that you have gained from any of your placements or any of your previous work. This could be in the community, this could be in a private practice, this could be working in a clinic as a lone worker, but you always have transferable skills that you can utilize, and an effective communication is the way forward. Have empathy for not just for your patients, but also for your team members, because everyone is going through the pandemic. We're all in this together. So really make sure that you understand where the person comes from, and have a better understanding of where your team morale is, and find ways to build team spirit. This could be a simple little game at the end of the day, or engaging in some kind of a Friday social, but it's really important that we maintain our morale and team spirit. There's a wonderful website called MindSpot. Do take a look at it if you get a chance. It's specific to coronavirus, the COVID-19 pandemic, and it talks about mental health and well-being and different ways that you can help yourself. And don't just reach out if you feel the pressure is too much, if you feel that work is getting too much, then I'm sure there's always ways to accommodate that. So you need to make sure that you reach out. We got this.
Thank you so much. That was amazing. There's so many nice comments in the book chat and coming through on social media. Students, physio students now. There's been so much done in education, hasn't there, to change the way that students can get their placement experience. But from your perspective, how has the pandemic affected student placements in education?
I feel like there's one of the things I didn't mention about is a lot of us are shielding at the moment, and there could be students that are shielding as well, who might not be able to have access, even though they have access to placements, might not be able to participate in this in their placements because of being a shielded worker. But there are other ways. It's very important that you speak to your tutor and make sure that what other options are available, because a lot of services are being delivered remotely. So there are still ways that you can be part of a placement. It might not be in an acute setting, but you can still have that experience of placement in a community setting or in a private practice through a telehealth. And those are the options that people need to look out for. You're on mute, Rachel.
There's just a couple of nice questions about what the jobs. The physiotherapy seems so like diverse. How do you even know where you want to specialize in?
Unless you're a magician, you're not going to know that while you're doing your undergrad, probably. But I think it's really important that you give yourself time to decide which specialty that you would like to go in. So I think it's very important that you go through your rotations, get a better understanding of working in different teams and different work environments. The experience that you would gain from an MSK rotation is completely different than what you would experience from an emergency department rotation. But you learn such valuable skills through each of your rotation, which you can then apply towards any specialty that you decide in the future. But I feel like if you go through that route of having that rotational role, it really gives you a good understanding of the profession and all the subspecialties that are involved and how they all come together. Especially in this pandemic, we've all come together as one team, but you will get a better understanding of working in those different departments.
And it's so hard because I think typical healthcare and education, we're all doing everything different. I think moving forward, we might see more combination of placements, virtual combined with practical. I mean, there's just certain things when you're a therapist, this is for all of the students, that you just can't do remotely. I mean, this is why we'd do it all the time, wouldn't we, for now? So I think there's part of that, but I think now we know more about this virus, and I'll hopefully be telling you a little bit more about that in a minute. We know how to protect ourselves and staff and students, and I think that's a hard thing when students don't have to go into red zones, they don't have to be exposed. I do agree with minimizing people's risk and exposure, but we're now in that fine line, aren't we, Ashwin, where we think actually we've got a commitment to education, let's get students back out there but keep them safe. I mean, do you think we're at that level now?
I do believe that, because where I work at the moment, we've had students on placements for the last couple of months and we haven't changed anything. It's just that having that communication with your university, having that communication where you feel like we're at that point where with the right amount of infection control strategies in place and with the right amount of PPE, there is no risk. Otherwise, I wouldn't be going to work every day. And that's important for people to know, that there are enough strategies in place, regular testing for staff at work, and there's no reason why we shouldn't have students in the red zone, because that's you can't stop learning at any point, and you still have to continue learning. And when there are opportunities, you need to make the most of that opportunity.
Well, on that wonderful note, I want to say thank you so much for coming back again. and then having to sit through my presentation that had no audio. So you're amazing. Thank you. You can catch up with Ashwin on Twitter as well. I will leave, when I edit this, I'll leave his Twitter handle. And of course, you've all got it now as well. So thank you so much for your time.
I've got my NHS email on the first slide as well. So if anyone wants to reach out, ask any questions, just feel free to reach out. If I don't know, then I'll reach out to my resources and I'll make sure that you get that answer.
Fabulous. Thanks so much. Right. I am going to try one last time. So the chat box is working, okay? I'm going to start, I think it must be something when I start sharing my screen. So I'm going to share my screen presentation. Please, can you just let me know? I'll turn my video off, so it's hopefully going to be better. Oh, hang on.
I'll stay for a bit, Rachel, just to let you know if I can hear you.
I'm going to share, and let's just see. I'm just clicking everything to try and make this work. Right, I'm sharing my screen. Can you guys hear me still when I'm sharing my screen? Online. There's a slight delay, I know, so I'm just gonna keep talking and hope that you can still hear us. And yes, if it doesn't work, I will definitely do that. I'll just do a pre-recorded and upload it onto this one. So far, so good. So that means you can hear me. Great, excellent. Right. You can see it, you can hear it. Yay, woo, yes. Okay, let's go. Oh, it was the end. That wasn't very good. Right, can you all see this? Yeah, see here the slides, fantastic. Okay, so these are some statistics. So this is from the 26th of January. And the 26th of January, there were 4,000 patients with coronavirus on mechanical ventilators in ICU. Okay, so this was people who were so critically unwell that they needed invasive mechanical ventilatory support. We had over 20,000 people with new confirmed positive tests in one day on the 26th of January. There were over 1,600 deaths in one day of patients that were tested positive for COVID-19. I mean, that's just terrifies me to think that there was that number of people sadly losing their lives due to this virus. And the screen shows us, the graph below shows us the wave since this pandemic hit us from March last year, February, March last year. You can see this first wave, we see the plateau. I mean, everyone keeps saying we're in the second wave, but really, I think we can say we've had 3 waves here. And for some centres, we've just never really got to a point where we've not had coronavirus patients in or ever had a period of just stability and calm. And this is where we were at the end of January. Now I'm going to flip back to that slide in a moment, but this is where we are from our, sorry, that should say the 19th of February, not January. So the data yesterday showed us there was just over 2,500 patients on mechanical ventilation yesterday in the UK. There were 12,000 people who had a confirmed positive test, and we had 533 deaths. So if I take you back to that slide, you can see the difference in numbers from between the end of January to where we are now on the 20th of February, so just over a month later. A very promising statistic is we have a 2/3 less death. So our death rate is 1/3 of what it was 1 month ago. But sadly, nearly 130,000 people have lost their life. And you can see here on the graph that this curve is now coming down, but we're certainly not out of the woods yet. Now, this is probably the most typical picture you'd see of coronavirus, and this is it under a scope, under a microscope, and this is like an infograph of the coronavirus. Now, COVID-19 is an infectious disease coined by the World Health Organization, caused by the new strain of coronavirus, the SARS-CoV-2. So the coronavirus family we have known about for a long time. For those of you that are old enough to know about the SARS virus, the SARS epidemic of 2002, 2003, or have read about it, this was the same group of virus families that caused that epidemic. SARS-CoV-2 is obviously a mutation or a difference in the coronavirus from SARS, and it's classified by this S-type protein. So this little red thing here, these spike proteins that you can see on the infograph, and this is how they get into the airway cells. Now, we know the predominant mode of transmission for SARS-CoV-2 is from person to person, and it's considered most likely via respiratory droplets from coughing, sneezing, or talking. You can't see it, you can't smell it, you don't know it's there. This is what makes it so transmissible. We know that this high level viral shredding takes place in the upper respiratory tract. So it goes in through the nasopharynx, and this is how it gets into the airway itself. And we know that this airborne transmission of COVID-19 is the primary cause of transmission for this virus, and that's why face masks really do work. I wanted to show you this slide because I think it nicely explains why we have this asymptomatic period in the first week. So this grey area here is when there's not enough high viral load where you can actually detect the virus if you were to have a swab. And what we see over the 7 days, so 0 to 7 days, is the viral load getting so high to the point people either become symptomatic or it can be picked up on PCR testing, so on nasopharyngeal swab testing. You get to your peak within this 10 days. So if you think about isolation periods being between 7 to 10 days, this is why. Because if you were if you'd been exposed to the virus and you'd contracted the virus, you would have a high enough viral load, it would be tested on PCR, or you would be symptomatic. And this is why after the 14 days, you would be considered non-infective, or you don't have enough, you haven't contracted SARS-CoV-2. So over time, you can see the viral load reducing, and this is when we get antibodies. So you get antibody detection in the blood after the first 10 days. So I really love these pictures, and I'm not really a fan of microbiology. So we have what we call the pathophysiology. Now, what I want to do first of all is take you down to this picture here, and I want you to think for a minute about a sponge and what a sponge looks like. So think about an old-fashioned yellow sponge. Okay, it's light, it's dry, you can imagine air would pass through it very easily, and most importantly, it hasn't got any water in it. Now, when a sponge gets wet, it gets very heavy, doesn't it? It gets very heavy and it changes the makeup of the sponge itself. And you can imagine it would be very hard for air to get through that. Now, when we breathe in air from the atmosphere, it comes in via our nasal passages or via our oral pharynx, so our oral cavities. We breathe it in, it goes down the lungs, so down the big airway tube, the bronchus, and it then goes into the lungs. And in the lungs are these small airway sacs called the alveoli that are like a sponge, but they're also like a balloon. So if you think about a deflated balloon, it's got no air in. You blow a balloon up, it's got air in, and it's a single membrane thick. And this alveolar sac that we can see here, and this is a cross section of it, fills with air. It remains a little bit of tension, and then when we exhale, the air comes out because it's transported around the body and it's picked up the waste gas, the carbon dioxide. When we have, so this is an alveolar cell, this bigger picture here. When we have a virus that tries to get into the cell, it needs to get in somehow, and these are what we call the Ace2 receptors. So they're basically the gateway to the alveoli itself. And these S-type proteins basically activate these receptors. And when they activate these receptors, as you can see from this part of the diagram, it allows the virus to enter the cell. So this is why this virus is clever, and this is why this virus is deadly in some situations, because it can get into the alveoli, and once it's in, it replicates many new virions very rapidly. So this is a cross section of the alveolar. So this is the bottom of the balloon. And when you have the virus that comes in, we have a really good immune response. So we have a really good immune response, which involves the bodyguards of the cells coming in to help attack this virus that comes in. And when it comes in, it brings what they call neutrophils, monocytes, lymphocytes, and these macrophages bring this protein-rich inflammatory fluid in. So if you think about your sponge, it's starting to get a little bit wetter. It's starting to get a little bit more dense, and therefore the air can't pass through very, very easily. And not only that, we'll have this capillary bed here, so the oxygen goes through this capillary bed to be pumped around the body. And we have the little blood capsules that come along, pick the oxygen up, and off it goes. But what we find in SARS-CoV-2 is we have this fluid that's coming. You see the monocytes, the neutrophils, the macrophages, they're all fighting the virus off. But it starts to damage this very thin layer of the capillary bed. And what also happens with damage, with trauma, is you get bleeding, you get activation of coagulation, and then you get the microthrombus formation. And this microthrombus formation is what gathers the blood cells together, this is very basic here, and causes the blood clots or the small pulmonary emboli. And what that does is it then stops the blood from coming. So if you've got a very dense layer where the oxygen can't get through, and then you've got poor blood supply, you've got clots, that's when there's a problem. So it causes what we call a ventilation perfusion mismatch. So what do we do? Well, people need to be admitted to hospital, and this is a small minority of patients, like I said. The majority of people will be asymptomatic, and when I talk about majority, it depends on the figures, but it's well above the 50%. You might have 30% of people that are symptomatic, and then you have the rest of the percent that will require hospital admission, and then you'll have a very small percentage of people that will require intubation and ventilation. Therapeutics have changed over time, and I cannot get over the fact that we declared a global health pandemic on the 11th of March. In the middle of March, the UK already had a randomized, well, it was a large pragmatic randomized control trial through ethics for approval, and they had a protocol which was designed to assess the effect of potential treatments for COVID-19, some of them listed here. And it was going to look at the early stage of infection, the pulmonary stage, and this hyperinflammatory stage, which I've just talked to you about. The recovery trial had ideas of drugs and interventions they wanted to study. At the time I wrote this initial presentation, there was 20,000 patients, but there has now been so many more, and I think it's nearly 30,000, if not over 30,000. Absolutely incredible that UK clinicians have managed to fight this infection, this virus, with the resource and capacity issues that we know we have, but also enroll people into studies. It's just incredible. So the researchers looked initially at these 4 treatment groups: dexamethasone, hydroxychloroquine, lopinavir, ritonavir, and azithromycin, and they randomized these patients to usual care. I'm going to just briefly take you through each of the therapies that were studied and what they do, okay, in a quite basic fashion. So azithromycin is a widely used antibiotic that reduces inflammation. And as I've explained to you, inflammation was a key feature of COVID-19. It was thought that azithromycin had some activity against the virus itself, and that was through some initial cohort studies and lived experiences from clinicians. So at the time, a total of 2,500 patients, just over 2,500 patients, were randomized to azithromycin and compared to over 5,000 patients randomized in usual care. What the preliminary analysis showed was no significant difference in the primary endpoint, so that was 28-day mortality. So what this showed, and I believe the trial was closed on the 27th of November last year to new patients, so from the end of March to the end of November, they recruited patients into this study, and they stopped to analyse the results and showed there was no difference in mortality with using azithromycin. So therefore, it is not recommended, and we do not use it in the UK. You might have heard of hydroxychloroquine because of some media attention, but also I believe President Trump was advocating this as an intervention, as a therapy. It's an anti-malarial and used to treat acute and chronic rheumatoid arthritic conditions. In the recovery trial, 1,542 patients were randomized, and they compared the drug to 3,132 patients who received usual care. It showed no significant difference in primary endpoint, which was 28-day mortality. And there was also no evidence on beneficial effects on hospital stay. So they concluded that there was no beneficial effect of hydroxychloroquine in patients hospitalized with COVID-19. And it was our use as a post-exposure prophylaxis, which I believe was being maybe suggested over in the United States and some other countries. So that was excluded. Now, lopinavir is a HIV-1 protease inhibitor, which combined with ritonavir increases the plasma half-life. So what that means is it increases the duration it will be effective for before it breaks down and it's no longer effective. It's a fixed-dose combination antiretroviral medication specifically for the treatment and prevention of HIV. So in the recovery trial, a total of 1,596 patients were randomized to lopinavir-ritonavir compared to 3,376 patients randomized to usual care. And there was, again, no significant difference in primary endpoint of 28-day mortality, and there was no evidence of beneficial effects on progression to invasive ventilation. So this was another drug therapy that was excluded following the recovery trial, and I believe again it was around November time they stopped recruiting patients into this limb. Dexamethasone, which you should have heard a lot more about, is a corticosteroid used for a wide range of conditions because it's an anti-inflammatory and immunosuppressive effect. So in theory, this should be a drug that we should have great faith in being effective for the cytokine storm / pro-inflammatory effects of the virus. So 2,104 patients were randomized to receive dexamethasone once a day compared to 4,321 patients randomized to usual care. What we found was 28-day mortality was highest in those that required ventilation compared to those who required oxygen alone, and lowest in those who do not require any respiratory intervention, which was not surprising. What dexamethasone did show was that it reduced deaths by 1/3 in ventilated patients, by 1/5 in other patients receiving oxygen therapy alone, but there was no significant mortality benefit for those patients who did not require respiratory support. So in terms of an effective statistic, 1 death would be prevented by treatment of around 8 ventilated patients, or around 25 patients requiring oxygen alone. So therefore, it was deemed an effective interventional therapy to be recommended for the treatment of COVID-19. So eventually, some good news, and that has now become a standard drug therapy that we would administer for people on oxygen therapy or requiring invasive ventilation. Remdesivir, this was recommended in the NICE guidelines. I'm going to touch on it because there is now no evidence to show that remdesivir is effective in treating COVID-19. So there is many a centre that do not use this, but it was recommended in NICE guideline. I know some hospitals are using it in the UK, and that's probably the most I want to talk about it, because certainly in the hospitals that I've worked in, remdesivir isn't used as a standard drug intervention now. There's uncertainties, but I have to say, hot off the press from the recovery trial, and if you go on if you just type in recovery trial COVID-19, you'll be able to go direct to the web page and get the results for yourself. The tocilizumab has been shown to be effective by reducing deaths, and if you look at the mortality data, if you were to treat 25 patients with tocilizumab, that would save one life. So that is seen as a significant mortality benefit, and it reduced mortality in the intensive care population from 38 to 33%. So tocilizumab is now a recommended drug therapy for those patients that meet the criteria with COVID-19. Sarilumab, it's again, the jury's out here. There's still ongoing trials, and is anakinra. They are both IL-16 antigen receptor modulated therapies. I don't know too much about it other than the jury's out. Convalescent Plasma was a trial for people who had been in intensive care for less than 48 hours and tested positive for COVID-19. Convalescent Plasma works by someone's had the virus, they've still got antibodies, you take the plasma out of them and you infuse it into a patient who's unwell. The trial's been paused, and I believe it may have now, again, hot off the press, been stopped completely because there's been no significant evidence of benefit from the recovery trial. But again, the most up-to-date information will be on the website. So that is a whistle-stop tour of therapies. Now I can see there's some questions in the chat, so I'm just going to go to them. Please do ask any questions that you might like as well, and if I can answer them, I will. What about the new strand that is in? How is that different from the other strains? So essentially it's SARS-CoV-2, but there'll be different ways that it will affect, or the different ways it can be picked up. So the very clever people who look at the vaccines do believe that the vaccines that we got will be effective against other strains. How the patients are presenting, we don't know if there's any demographic change. What all we know is when we have a patient that's COVID-19 positive, is that COVID-19 positive. We don't really know anything too much about the microbiology behind that. So that's probably all I can say on that. How long do I think it may be until things can get back to some kind of normality? Oh, this is so depressing. But I mean, we're in the end of February now, and I can't see any kind of hard lift of lockdown until the summer. Will we be wearing masks the entire year? Yes, I think we will. Will we have social distancing for this year? Yes, I think we will. That is just my gut feeling, but I'm not an epidemiologist. But that's what I'm planning for. That's what I'm planning on my patients for, our teams for. Who knows with the vaccine though, and I think we haven't seen the vaccine effect yet in terms of ICU and the effects on patients, etc. There was another question further up. Sorry, I'm just going to go up. Do we think will be more waves? That was one of the questions. Oh God, again, this is so depressing, isn't it? But yes, I think we will, because we haven't got any of the lockdowns right. Did you remember from that graph when it went really low? We had really low numbers, and then we lifted out of lockdown and they went up, and we had new variants, and we didn't have a vaccine. We didn't have the vaccine rollout. So the only way of not having another peak, in my opinion, again, not an epidemiologist here, but I think is to stay in lockdown until we've got the nation vaccinated with at least one vaccine. And then when we come out of lockdown with the nation vaccinated, with border control, then only then will we be able to start getting back to the normality that we know it, but with social distancing and mask using. So that would be my limited way to answer that. Are we predicting another waves? Yes, we are. As acute physicians, clinicians, we are predicting other waves. We will still be preparing for surge, etc. So yes. So the great question, can we be hopeful about 2022 at all? Yes, I think we are, even if it's for mental health well-being. Why are there different names for the vaccines when they're all the same thing? So that's just pharma. You have that with inhalers, you have that in anything, that's just pharma. But essentially they'll probably work differently because they'll be patented, but essentially do the same thing, yes. Do we think we'll be wearing masks in the winter? That is a really good question. I was asked this on another presentation, and I worked in Japan in 96, 97, which I know was quite a while away. Well, it's over 20 years ago, but and I just remember everyone wearing masks then. I went through my pictures to check. So I think some of that was around pollution, and some of that was around, just the culture, but there was something around transmission of respiratory disease as well. So can I see it? Yes, I can. I can see it becoming part of a winter plan in terms of reducing winter flu, seasonal flu, etc. Oh, vaccine hesitancy. So this is so complex. It's so complex for different reasons. It's different for different subgroups of communities. For example, people from Black, Asian, minority ethnic communities might have vaccine hesitancy for completely different reasons. You might have an anti-vaxxer as reasons. So I've had my eyes open with regards to vaccine hesitancy. I really do. As a manager, for someone who thinks it's absolutely a no-brainer, it's not as simple as that. So there needs to be a lot of education. Do I think everyone should have the vaccine? Yes, I do. And that is for simple scientific reasons. You know, we're all scientists to some degree in healthcare, so that would be mine. But does there need to be education? Does it need support? It needs to be non-judgmental as to why people might have concerns. So that I hope every manager takes that approach. I'm very lucky because I have people I can talk to about this and understand. But yeah. So some ethnic minorities have a problem with the vaccine. They don't want to take it. What more can we do? So there is some amazing vaccine webinars led by leaders of our country. Please go on and have a look at some of them. I've certainly tweeted about them. If you just put into Google NHS vaccine presentations webinars, they will come up. Some really high level presentations. Please, they're all free. You can download them, and I can definitely put some links on the Twitter page and on the YouTube. I'll try and do it through YouTube as well. So yes, lots of people don't like wearing masks and social distancing. There's lots of things we don't like to do, but I think it's just what we have to do, and it's about prevention. And if I think back to, I don't know if anyone's seen It's a Sin. I have yet to watch it completely because I want to sit down and binge watch it when I've got a day off. But if we think back to prevention of sexually transmitted diseases and wearing condoms, people didn't really want to do that in the day, but look at the public health effect that's had. So I know it's probably quite a bizarre, correlation, but I genuinely believe this is a public health message that we need to think about for the future. Especially the impact it has on healthcare, acute and mortality. So yes, I think that would be a thought for me. It's a public health message. So I think we've got through all of the questions, and I will definitely, there's a few things about the vaccine webinar, so let me definitely put some links up on Twitter about them, and I'll post them in this box on the YouTube. So thank you so much for your time, everyone. Really appreciate it. So sorry about the technical difficulties. I don't know what happened, but we got there.